Yeah, you can start.
Yeah, thank you, Sajita. Good afternoon, doctors. This is Dr. Someshwar from Shield Health. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Sridevi Nalimarla, who is a consultant, ops and gynec, also fertility specialist at Sri Clinic, Vizag, and she graduated from Andhra Medical College in the year of 1998 and graduated from the same college for post graduation in the year 2002. And she had fertility training at Kiel University, Germany, and she worked at Krishna Hospital and IVF Clinic from 2003 to 2013. And she's a member of Foxy, ICER, and she's a avid learner of ultrasound in ops and gynecology from Ian Donald School and participated in research activity at Krishna IVF Clinic. So with this, we welcome you for today's webinar, ma'am. And present webinar is streamed through the Shield Connect, which is the web page of Shield. And I request all the delegates, please do see the Shield Connect web page. And if you miss any part of this program, it will be available in the Shield Connect. And coming to the today's topic, as we know that sperm morphology not alone, also along with the DNA fragmentation can affect the success rates of IVF and ART. So with not wasting much time, let me turn over the time to Dr. Sridevi ma'am to talk on sperm morphology and DNA fragmentation. Over to ma'am.
Thank you, Dr. Someshwar, for the kind introduction. And thank you, Shield Connect, for giving me this learning opportunity. I'm here to share sperm morphology and DNA fragmentation. So spermatogenesis, we have all read that Sertoli cells are the nerve cells which they form a tight junction. They are the strongest intercellular barriers in the body, called the blood-testis barrier. The germ cells undergo mitosis and meiosis to form spermatogonia, primary spermatocytes, secondary spermatocytes, and spermatids. In the spermatocytes. So this is the basically the from the diploid to the haploid sperm. It undergoes mitotic and meiotic divisions, and finally the spermiation. The spermatid becomes the spermatozoa by lot of cytoplasmic modulation and acquiring the peculiar shape. The sperm function tests are many, out of which the basic semen analysis, which we do routinely, and it is an essential component when assessing male reproductive capacity. The semen analysis incompletely provides a comprehensive assessment of male fertility potential. The sperm function tests, they add important data regarding sperm ability for fertilization and impact in post-embryo development. The use of sperm function tests in conjunction with semen analysis contributes more efficient treatment strategy for us to follow. So as we look at a healthy, viable sperm, it has a structural sperm features, the head and the tail and the midpiece. Morphofunctional sperm features like motility, the abnormalities, and sperm membrane integrity and functionality, and oxidative stress. The intrinsic sperm features like the sperm proteins, organelles, and mRNAs and mcRNAs, nuclear RNAs, and mitochondrial RNAs are also intrinsic to the sperm. So all of these contribute to the healthy, viable sperm. When we look at the semen analysis as such, at the morphology, we can see the abnormal head shape, size, and other things of the head and midpiece and tail, whereas we cannot see the functional form, the viability and the intrinsic sperm features which can be assessed by further testing like DNA fragmentation index. So the basic function of the sperm is to fertilize an ovum and contributes chromosomes to the zygote. The sperm functions, including their potential for movement, cervical mucus penetration, is important for capacitation along the genital tract, female genital tract, and the zona recognition, the acrosome reaction, and sperm oocyte fusion. So in the history, we have seen that there are 6 editions trying to quantify the sperm parameters which lead to optimal fertility. We've seen the editions have changed from first to 6th of the latest, and it has become from the volume from 2 ml to 1.5 ml, the numbers have been different from the initial quantification to later on. And now it is standing at 1.5 ml the volume. The total sperm number should be 39 million and the sperm concentration of 15 million per ml and progressive motility of 32%, the type A motility, and the vitality 58%, and the normal forms by 4%, the strict Kruger's criteria. So sperm have to go through have to navigate through the female genital tract. They have to, once they are inseminated in the vagina, they are in a higher number. They have to swim through the cervical mucus, the uterus, the uterotubal junction, and at the isthmus they are decreased in number to 10 to the power 3, and the cumulus cells finally to the zona pellucida. Once the sperm membrane attaches to the ulema and discharges its DNA. So in the semen examination, the routine we see the macroscopic parameters like volume, appearance, color, liquefaction, viscosity, and pH, and the microscopic parameters like the concentration, motility, morphology, and leukocyte concentration in particular, and agglutination. So assessing the sperm morphology, a drop of sample is placed in the sterile side and covered in cover slip, and we know this name and sample ID is mentioned, and the sample is viewed under 40x 40 times magnification, and a normal sperm has a smooth oval shaped head which is 4.5 to 6 micrometers long and 2.5 to 3.5 micrometers wide, less than the size of a needle point, and the well-defined acrosome cap that covers 40 to 70% of the sperm head, and there are no visible abnormalities of neck, midpiece, or tail, and no fluid droplets in the sperm head that are bigger than 1/2 of the sperm head size. So roughly, if we look at these measurements, it is sufficient. So the structure of normal spermatozoa, it is oval in shape. It is the head contains the nuclear region, and it is of these dimensions 4 to 5 microns and 2.5 to 3.5 microns in length, and the acrosomal region is 40 to 70% of the head area. The midpiece is the metabolic region. It is slender and less than 1 micron wide. It is around 1.5 times the head of the size of the head, and it contains the axoneme and circular mitochondria. The cytoplasmic droplets less than half the size of the normal head. The tail is the locomotor region. Straight, uniform, thinner than the midpiece, uncoiled, and the approximate length is 45 microns. So looking at the Defects are, they can be various defects, head defects, neck piece and neck and mid-piece defects and tail defects. It can be a detached head or a large or a small head, elongated head and vaculations, irregular shape, amorphous shapes and small acrosome or no acrosome. The neck and mid-piece defects, we can see the asymmetric attachment of the neck, bent necks, thin neck and thick, irregular midpiece, thick midpiece and cytoplasmic droplets. The tail defects can vary between coiled, short, hairpin bends and broken tail or duplicate and terminal droplet. So these abnormal spurs we can see in the microscope after staining. So the following categories, all these categories should be noted down, and one sperm can have multiple defects. Also agglutination, we will also look for head-to-head or tail-to-tail agglutination, and first cell spur, high power field, the debris, and after completion of analysis, results should be noted in the record and typed in the patient report entry column. So for correct, accurate morphological assessment, we have to stain the slide. This, by the morphological assessment as we have discussed, by Kruger or Tigerberg criteria, the sperm head being oval, smooth, symmetrical outline and common dimensions, and the head should also have a well-defined acrosome area of 40 to 70%. And vacuoles less than 2 in number, and that occupies 20% of the head area. The midpiece must be straight and slender and half micron in width and 7 to 8 microns long, straightly aligned to the head. The tail must be straight and 45 to 50 microns long. To be classified as normal, the sperm must be normal in all portions of head, midpiece and tail. And at least 400 sperms must be scored on randomly chosen field. The normal forms are the percentage of normal forms being normal ratio between normal sperms to total number of sperms evaluated in multiplied by 100. So the Diff quick staining is a simple quick staining method. Moderate differentiation of structures, so the acrosome is stained red and post-acrosomal area is dark red. Very thin smears are necessary as the background is influenced by the presence of protein in the seminal fluid and tends to be dark, otherwise dark. And then the slides are fixed with fixative and Diff quick for 1 for 5 to 6 seconds, clean water 2 times and remove the excess moisture. Again, Diff quick 2 for 10 seconds and 2 to 3 dips in clean water. It is left to dry by standing the slide on one end on absorbent paper towel. These sperm stained by Diff quick are larger by comparison to the hematoxylin EFN staining, as the cells did not undergo dehydration by alcohol. So these are the abnormal sperm. If we look at this a polymorphometry cell, and the spermat is immature sperm cell, and this is the round shaped head, globosospermia. Important to whenever we see globosospermia, these patients must be counseled that they can achieve pregnancy through ICSI, but it can transmit to the male offspring. And then this is the dead sperm, this is the macro head, and this is a normal looking sperm and multi-head. So also triple head sperms, acrosome activated, reacted, and tapered forms, which you see in varicocele, and missing acrosome. So morphological assessment is subjective and varies from person to person. So due to the wide variation in sperm size and shapes, and percentage of normal forms correlates well with the fertilization rate in vitro and pregnancy rate. Sperms with defective heads are more likely to be immotile. And so motility is an indirect assessment of quality of the sperm. So, and defective motile sperms tend to show sluggish motility as compared to normal sperms. The vitality assessment, the eosin nigrosin stain, the dead sperm stain pink or red, and eosin 1% dead sperm stain pink or red, with trypan blue, the dead sperm stain blue. So there is another test, hypoosmotic swelling test. Live sperm shows tail curling, and so usually 1:1 ratio of semen to dye mixture mix well and smear onto a slide. Feed immediately at 40 objective and count 200 sperm. And we can choose live sperm for ICSI in hypoosmotic by doing hypoosmotic swelling test. Dead sperms will not react in hypoosmotic solution, while live sperms will take up roots, causing their tails to curl within 5 minutes. And they stabilize at 30 minutes. Therefore, viable sperms can be selected for ICSI. So this is the live sperm showing tail curling and dead sperms in staining showing pink or red. So other these methods of staining, tapeniculi, Shar staining, and rat staining procedures. Again the large or small head defects, tapered, amorphous, and piriform round heads, and acrosomes more or less in its coverage, and no acrosome. And small vacule, you can see the large vacule and multiple whitish gaps, and then post-acrosomal vacule, and this is a double head. So types of principal piece, midpiece can be insertion at asymmetry and the bent neck, the size being thick or thin midpiece, then the bent tail, the tail abnormalities of double in the short tail and coiled tail, irregular width along with length, and excess cytoplasmic residue. So improving the diagnostic evaluation, we do a minimum evaluation of a man with suspected male infertility by a complete medical history. We have to take allergies, infections, respiratory infections in particular, respiratory allergies, and lifestyle and medications that he is taking, and a complete physical examination looking at the secondary sexual characters and testis and varicocele exclusion, and 2 semen analysis done 8 weeks apart and assessed using WHO criteria. So interpreting semen analysis, normal semen parameters, despite looking normal, sperms may still be damaged. Reactive oxygen species damage can lead to DNA fragmentation, and poor sperm semen parameters like oligospermia, actinospermia, and teratospermia, we have to make a note, and azoospermia, obstructive or non-obstructive, we have to see. So further evaluation, whenever there is an abnormally low sperm count, impaired sexual functions, we have to do a basal serum FSH and testosterone. And when the ejaculate is less than 1 ml, maybe due to ejaculatory duct obstruction or a retrograde ejaculation or anejaculation, hypogonadism, or a CVAVT, And scrotal and transrectal ultrasound uh, identify and rule out varicocele, testicular mass, absence of VAS, and obstructive pathology. So other investigations, sperm DNA integrity. The genetic screening helps in diagnosing the cause of azoospermia. It helps in counseling, importantly, that about the risk of transmission to offspring, even if we find sperms in the tissue sample. And the three main genetic factors we see are cystic fibrosis, gene mutation, and some chromosomal abnormalities resulting in impaired testicular function, and Y chromosome microdeletions associated with isolated sperm impairment. So, the approach to management should be focusing, identifying correctable factors, if any, and giving importance to the focusing on the sperm health, treating infections if there are cells in the sample, and going about the ICSI or ICSI and PSA ICSI if indicated, as and when indicated. Improving the health of sperm is very important because of late we are seeing more of DNA damages, and because human sperms play an extensive role that extends beyond the early stages of fertilization to include abnormal embryogenesis. This has not been stressed in the previous years, but now in this 1-2 decades, a lot of studies have come in which have laid the importance to sperm DNA fragmentation. And so DNA fragmentation can be single strand DNA break or a double strand DNA break, and base deletions or modifications, inter and intra strand cross linkages. So why should we worry about the sperm DNA fragmentation? It is a useful biomarker because morphologically we may see a normal sperm, but there it may be having a damaged DNA. So male infertility diagnosis, it is a useful biomarker and a better marker than conventional semen analysis, and it predicts assisted reproduction outcomes. So if we see repeated IUI failures or long marital life, we have to look into sperm DNA fragmentation and try to correct it. So reduced fertilization rates, poorer embryo quality, poorer pregnancy rates, and higher rates of spontaneous miscarriages, and higher instance of childhood diseases in the offspring. So we have to correct the sperm DNA fragmentation and select a morphologically as well as functionally normal sperm for ICSI. So looking at a few data from studies, there is a high immobility is associated with high sperm DNA fragmentation. So who benefits from sperm DNA? Okay, the couples with unexplained infertility, with the history of unsuccessful IVF cycles, and couples with history of recurrent miscarriages, men over 30 years of age, and men at higher risk of reactive oxygen species damage, like men with diabetes or obesity or with history of drug abuse or exposure to radiation or who have been treated for cancer and cancer therapy. So what basically causes sperm DNA fragmentation? The source of reactive oxygen species is sperm itself. In its process, there is the intrinsic factors and extrinsic factors. The intrinsic factors being contamination failure, oxidative stress during transit or after ejaculation, and apoptosis during sperm maturation inside the tubules. So a lot of intrinsic factors are, but which are corrected usually by scavenger cells, uh, vitamin E in particular, and extrinsic factors like lifestyle, smoking, obesity, varicocele, genital tract infections, and radiation exposure and exposure to toxins such as lead, phthalates, which are very common in personal use products and paints, etc. So these can cause a sperm DNA fragmentation. So how to diagnose DNA? There are various assays. The Comet assay, which is a single cell gel electrophoresis, and detects actual DNA strand breaks and measures existing damage. Tunnel assay, the terminal deoxynucleoside transferase mediated UTP chain labeling. It detects actual DNA strand breaks and measures existing damage. It can detect both double strength and single strength breaks. And sperm chromatin dispersion, that is a halo sperm test, we use it commonly, measures the susceptibility of DNA to denaturation, the formation of single stranded DNA from native double stranded DNA, and estimates the potential future damage. Sperm chromatin structure assay measures the susceptibility of DNA to acid-induced denaturation and estimates the potential to future damage. It is the only test with clear and clinically useful cutoff levels for calculating male fertility potential. So when most studies have defined an upper normal limit of the cells with DNA fragmentation, the samples with assay results above this threshold are considered to have high DNA fragmentation. So normal values, a good fertility potential is the spermatozoa fragmented DNA less than 15% in the sample, and with average fertility potential between 15 to 25% of the sample, and spermatozoa with fragmented DNA more than 25 to 30% have a poor fertility potential. So how to manage and go about the high sperm DNA fragmentation? So we have to advise the lifestyle modification, cessation of smoking. Smoking has a direct relation to the DNA damage that we, and it is proven. And alcohol, though not directly proven in studies, alcohol intake and obesity, BMI more than 30, you have to treat these. And antioxidants should be used at least for 2 to 3 months, extending up to 6 months. The most common and cheapest is vitamin C, 500 milligrams per day, 500 to 1000 milligrams a day. Vitamin E, we can use as high as up to 800 milligrams a day for 2 months. And the folic acid, 2 milligrams per day, zinc, 25 milligrams per day, selenium, 26 to 100 micrograms per day. And treatment of underlying pathological conditions like varicocele, genitourinary infections is a must, along with these antioxidants. Avoiding the environmental exposure to toxins, the awareness on dietary awareness and if possible to avoid occupational exposure and judicial medical use of radiation, and also reducing the abstinence period or serial ejaculation every 24 hours reduces the DNA damage by about up to 25%. So in cases with uncorrected DNA fragmentation, you can consider surgical sperm retrieval. So these are the various studies with evidence of Jimmy et al. In 2008 there is a meta-analysis. So the embryos with high sperm DNA damage are associated with early pregnancy loss. This is the most proven association between the sperm with DNA damage and recurrent pregnancy, early pregnancy losses. And again, in 2009, there was an increased, modestly increased pregnancy chance after IVF in cases with low level of DNA damage sperms. Dumolin et al. In 2010 have shown that in ICSI sperms are injected into the optimal environment of the plasma within a few hours of ejaculation, thus reducing the chance of lab-induced damage to sperms. Then also Simon et al. In IVF couples with low levels of sperm DNA fragmentation had a live birth rate of 33%, and the ones with high levels of sperm DNA fragmentation had live birth of as low as 13%. And another study by Zinn, the sperm DNA damage not found to be predicted for ICSI treatment. In the 8th skin in 2012, sperms from up to 40% of infertile men have high levels of reactive oxygen species. Robinson et al. High levels of sperm DNA damage are associated with increased risk of pregnancy loss, regardless of the in vitro technique applied. And again, Simon et al. In 2013, the have given large ratio of 76 for clinical pregnancy when the mean DNA fragmentation for spermatozoon was less than 52%. In another meta-analysis in 2015, the live birth rate was lower for high sperm DNA fragmentation in IVF cycles, but there was no difference in live birth rate between low and high sperm DNA fragmentation with ICSI. So the effect of this is a paper by Dr. Sayali Kandari in India. The effect of combined astaxanthin, selenomethionine, CoQ10, vitamin D3, and sperm DNA fragmentation in several parameters in a single case study on subfertile male partners with primary or secondary impact. So the study question was effect on sperm parameters and chromatin integrity post 3 month usage of combined supplementing subfertile male partners. The study design, it was a single arm cohort study, prospective study. The patients number was 67, and final 50 cohort study analysis was done. And so the results were 57% reduction in female sperm DNA fragmentation and 20% to 8.7% in moderate DNA fragmentation index patients and 38% in poor DNA fragmentation patients. So there is no significant differences in motility, morphology, or concentration. So we will see. And whereas DNA fragmentation reduced to 15% in 94% of all the patients treated. So the methods were sperm chromatin dispersion assay, and analysis was done by the WHO according to WHO guidelines. The subgroup for poor or moderate DNA fragmentation by 30% or more than 15%. Thank you all.
For the wonderful talk and for excellent presentation. We are very honored and learning. Ma'am, if you have me, then we'll. Hello.
Hello.
Yes.
I cannot hear you. Hello. I think
hello.
It's coming in breaks. Your voice is coming in breaks.
Okay, ma'am. Yeah, ma'am. Now is it fine?
Now better.
Ma'am, thank you, ma'am, for the wonderful presentation. Ma'am, if you allow me,
Thank
then
you,
we'll take
doctor.
the questions. Hello.
Hello.
Yeah, ma'am. If you allow me, then we'll take the questions.
Yes, yes.
Yeah. Ma'am, we have first question. Hello.
Yes.
Yeah, that is, does the treatment of erectile dysfunction in diabetes will improve the sperm count?
When you look at the erectile dysfunction treatment,
Yes, erectile dysfunction in diabetes.
So that's a
Whether
separate
this
pathway.
treatment
The pathway for erectile dysfunction is a separate pathway for it. And if you are adding a antioxidants to your treatment and correcting diabetes, then the count and motility might, especially the motility. When you look at the motility, if it is improving, then you can say yes, there is an improvement in the sperm function as well. If the couple are unable to undergo DNA fragmentation every time. So HbA1c of more than 7% is associated with more damage to the DNA. So we have to aim to HbA1c below 7% and give antioxidants for another 3 months from there, from after the correction of diabetes. Then you have to reassess the DNA fragmentation and go ahead with our treatment protocols.
Thank you, ma'am. Ma'am, we have one more question. That is, can we include sperm DNA fragmentation in a routine workup for RPL?
Yes, if it's in a if it's in a low resource setting, and you have to look at the application as such. If all the other factors are normal and you're not finding any cause for the recurrent pregnancy losses, these are associated with more of early pregnancy losses, where there is just a biochemical pregnancy and you see the loss. Most often the DNA fragmentation index is high. So you can include, especially now with the lifestyle that we are seeing of sedentary lifestyle and the food habits of people and exposure to toxins, environmental toxins, the pesticides that we are exposure. You can include in the RPL evaluation of recurrent pregnancy loss. This is an additional tool for counseling purpose, because many, if you see, they do not use the simple vitamin C. They are very reluctant to use because they complain of gastritis or some digestive issues. And they are usually very, very reluctant to use any medication. So unless my count and motility, everything semen analysis done elsewhere is normal, why should I use these? So then you have to counsel properly regarding the DNA damage that happens and how the reactive oxygen species in excess can lead to the DNA damage and how it can affect the generations to come.
Yeah, thank you very much, ma'am. And there are no more questions from the delegate. If you allow me, then we'll close this webinar.
They can also mail to me if
Sure, ma'am. If any further questions are there, we will mail it to you.
okay. Thank
Thank
you,
you.
Dr. Samesh.
Yeah, thank you very much, ma'am. And we look forward for your continuous support for the future educational activities as well. And many thanks from the Shield team, and also thank all the delegates for active participation. Thank you very much, ma'am.
Thank you. Thank
Yeah,
you.
ma'am. Yeah, thank you very much, ma'am.